gentlemen. Terrific. Fred Guthrie is the Vice President of Value-Based Payment and Insights at Edifecs. More importantly, he's just a gentleman, somebody I call a colleague and a friend for a number of years, transcending multiple companies, and been on many projects with him, but that even goes even further back. So I'd love to introduce him further, but I think he could do that much better. Fred, can you introduce ourselves and let us know your, I'll blow it for you, your 30 years in healthcare and what you've focused on for that time?
Yeah, thanks, Mike. And gosh, I don't really know where to start, but yeah, I'm showing my age, and it's been 30 plus years in healthcare technology. One of the first projects I worked on in healthcare was with the CDC, helping to stand up one of the very first online epidemiological research projects back in the days of modems and dial-ups and all kinds of fun phone banks systems. So that doesn't show my age, nothing else will, but we've moved thankfully a long way since then. But from there, I was one of the founders of a company that got some early patents in episode technology back in the day, and we worked closely with a number of health plans, getting them signed up for value-based contracts, building value-based provider networks for some of these plans, doing a lot of, for instance, ROI studies for some of the early episode programs and some of the early value-based programs, really trying to, we're in the stages back then of identifying where opportunities were, why there were variations in cost and care and things like that. And as Mike has alluded to and will continue to allude to, back in the days where data was very disaggregated, it was hard to get the types of information you needed to do those types of population-based studies. But in any case, been working in the industry, building systems and processes and doing consulting around value-based stuff for probably 20 plus years at this point.
Well, thank you, Fred. And, in the beginning, based on the white paper that this work group is going to be creating and presenting, in the very beginning, was it simple? I mean, you've talked about some of the technology struggles, but the design of programs back then, I know you worked with a number of payers. I know you worked with a number, that had provider network kind of stuff. What were some of the type? And I think you were even involved with one of the earliest, I think it was the ACE program. Can you just talk about, in the beginning, what programs were in play, in the early, 2000, 2001 timeframe?
Well, there weren't a lot of programs at play. I mean, most people's experience with anything that had to do with, I guess you would call it payment reform or some type of structured, payment arrangement around coordinated healthcare was the HMO concept. So people knew what an HMO was, but it was a dirty word for a lot of people back then. So working in the industry, trying to get past some of the preconceptions and start talking about how do we improve the cost of care and the quality of care, yet not overburden providers. It's been a long journey. And one of the things that we started, the whole crux of the issue had to do with providers. I mean, I know things have changed and the industry shifted a good bit over the years. Back in the day when we said a provider, we were generally talking about a single doc practice or a small practice. And today you say provider, it could be anything, huge organizations, facilities, single docs, but it kind of covers a broad spectrum. But back then, we were boots on the ground trying to convince individual providers why they needed to sign up for something like this, why it would matter to them 2 years, 5 years, 10 years down the road. And, even working with health plans and with providers, half of the work was sitting down and convincing providers that they knew what was going on, they understood what was being proposed, and then you would, go through, well, we have all the clinical data and all the clinical expertise, and we're going to, you can't do this episode because of X, Y, and Z, and the payer's like, well, we have to do this episode with these definitions. And by the time they came to the middle, you might be saving 5% on what they were originally going to spend, and there was really zero risk for anybody involved except the payer. So there was very little relevance to what was happening other than shaving some dollars off the top of spend. And it was a very challenging thing. And as we got into even more complex arrangements, it was typically black box style calculations and payments or non-payments being paid from the plans to the providers. So it was a fairly hostile environment, at least where I was working with the providers and with the payers, trying to get them to meet in the middle and understand what the opportunities were and how we could partner to bring these programs forward. So it was, it was tough going early on. And, as we discussed, I think the other day, we were having a conversation about this. Even when you had agreement on how to do something, like we worked with the hospital system, and they were working on some workflow improvements and process improvements to help increase their efficiencies and find ways to provide cost savings and make a better patient experience and things like that. But they simply didn't have the technology infrastructure to support some of the recommendations. So, for instance, their imaging center, their radiologists were off-site, and to send the images, they had T1 lines, if you remember what those are. And they were high speed back then, but it would take hours for all these images to get sent over and queued up in somebody's system. And meanwhile, the patient's waiting on a read, the doctor's not sure whether to admit or whether to discharge or whether to do a procedure. And it was really difficult because of some of the infrastructure to do simple things like process improvement within a hospital or within a big provider network.
So tough times. So the beginning was tough, but the concept was there, right? So we went through, the Medicare with the shared savings program, ACOs, a number of states, Oregon with their CCOs, the state of Massachusetts, was one of the first, right before the ACA. They had their own, mandate for insurance. So there was a lot of things happening. But I get your cats and dogs. It really was, and it may have been hangover from the old HMOs. But can you talk a bit about today? I know it's a great leap to go all the way from the early days of, and I think T1s are pretty quick, right? So, but anyway, where the technology has helped us, today's contracts, the great things that, the highways that are being built and supported by WEDI, CAQH, the quality measures of NCQA, today's programs, how they're laid out, how they're showing savings and improvements in health. And then the complexity, if you could talk about, some of the complexity and how that's being handled.
Sure. And I mean, before I answer that, though, I will go back a little bit, because that's where I was getting to with some of this early work. We worked so hard to get providers engaged in value-based contracting and value-based payments. Yet I feel like there was sort of like the dark ages from then until now, where we put all these burdens on providers. Every year there were more and more measures, there was more and more reporting, there were more and more things to comply to. There was process improvement, now, outcomes improvement, and, efficiencies and member satisfaction. We put all these burdens on the providers, yet we did very little to truly incentivize that work. And then where the incentives were there, we did very little to actually assist the providers in getting from point A to point B. And we had government mandates around, in help. There's the ACA, and there was money to potentially modernize, and you got some incentives to do certain things. But then over time, those became disincentives to if you didn't do those things. So it's been a lot of back and forth about how to get providers truly engaged, how to get providers to, see the full picture, and how to help them be successful in a value-based arrangement. Risk, we talk about risk, and it means so many things to so many people, but, for providers, risk is the bottom line. I mean, risk is practicing or not practicing. Risk could mean, a good year or a bad year. and we say, we've got risk for individual members on a risk score. You've got risk of not, submitting things to CMS with the proper coding. You have various risk models about population health. But what does that mean to a provider when it comes to meeting their contractual terms? What does it mean for a quality score when it comes to improving their practice and reducing the overall population risk? So that's what, the question now, finally getting back to it, where you're saying with the technology we have and with these value-based designs that we're getting to, I think we're finally in a place, and the industry is finally getting to the point where they're kind of globally recognizing that if we don't do more things to support provider success, we don't provide more tools to provide kind of a transparency in these programs to give more information to providers to say, this is your true population risk. Okay, what do you do about that? Or if you have members who you provide services to, and for instance, in an episode of care or some other model, how to truly adjust for the risk of not just the population, but for that member. There's ways in which we can help providers, know sooner who's going to be a problem, know sooner when somebody has an episode like a maternity episode. It just doesn't have to be something that you decide after the child's delivered. You should know it up front when the person is diagnosed or has an ultrasound or has a lab test or has, a coding that says a pregnancy started. There's no reason with our systems today that we can't help providers understand something has happened, see what the risks are up front for that member, both historically and predictively, and then to help them through that journey and incentivizing them to provide good care and good outcomes.
That's
So,
yeah, that's great.
yeah.
And you're defining how we've transitioned from some of the, single threaded type of payment models to, some progressive, so it's not just retrospective and we're taking a review and you're going to find out in 8 to 10 months how you performed last year. It's more perspective, where we're able to forecast and give that. And you started on risk adjustment and all that. So is that, many years ago, it was not too uncommon to hear that from a payer, from a CFO, saying that we have these value-based contracts and we don't even know if we're paying for performance or quality. And then you would hear from the providers saying, well, I got a bonus payment or I didn't get a bonus payment, and I don't know how to break down the reports. I don't know, when they sent me this, what did I do well? Can you talk about some of the technology today and some of the payment streams and how settlements are more clearly articulated?
Sure. Well, I think that it should be a requirement for any company, any system, any plan making payments to providers to show the impact of any given member at any given point in time for any given payment. So what members contributed to what quality measure, what members contributed to the measures going up or down, what members were attributed at what point in time and have contributed to their payment, whether positive or negative. That to have the insight both at that point in time, at the time of payment, to have really very clear ways in which your models can adjust after a payment for something that was going through the system, but like retroactive payments and things like that. There's just a lot of things that providers don't understand, or they just deal with because the payers send them a report or the payers send them information, or they're at the mercy, employer groups, self-insured or anybody submits membership rosters. Sometimes they're late, sometimes they're wrong. Sometimes it takes 6 months before they figure out which member really belongs in which plan or line of business. And they have to do an update, and providers get this bill that says, well, you had 100 members we had to pull out of your plan and we already paid you for them, etc. There needs to be better transparency across the board for member movement across contracts, for member movement across attribution, for member movement across their risk profiles, and member movement for their quality measures. And then just kind of adding on to that, talking about quality, that's another area in which we think that the flexibility and the technology and the systems has come a long way, because there was a lot of great work done and is being done with a lot of the standards bodies for the quality measures, CAQH or NCQA and other bodies like that. But providers, we set structures and we set goals for providers, we knowing that both clinically and financially, if you're able to reduce this, that members potentially will have less readmissions or less length of stay or less health complications. But really, for the modern value-based contracts, we're seeing more and more that while the terms of the contracts are getting more standardized, the goals, the quality goals and outcomes goals are becoming more and more specialized. So if you don't have the ability to set more customized goals along the lines of, I have a provider network that I've contracted and our first pass rates or our care gap closure rates are pretty high. And so one of the goals we have is not just along process or outcomes, but on closing our gaps of care rates. That can be a quality measure, a custom measure set up for the providers that has a financial incentive. Same thing with social determinants of health. There's no reason to not be able to have social determinant-based quality measures or outcome measures, or even program designs built around certain cohorts that can have a more positive impact and have the right providers in that contract versus sort of a come one, come all approach and taking all the PCPs and some specialists and throwing all the members at them and then hoping they can coordinate care. There's more precise ways to set up based on the profiling, the risk models, the health needs of members, social determinant, even some of the health equity issues to better address those. So some of the old traditional and standard sort of CMS 30 plus ACO measures or whatever, those are great, but we have to have more flexibility in targeting these programs to those most at need or most at risk, or providers who have the most, know where they are in their journey and be able to set program designs and program models to help serve them better as they progress from, tier 1 to tier 2 to tier 3 capabilities and membership.
Great. And you touched so many different parts there, but the health equity, our sister work group is going to be tackling that. We'll be joining up with them in the future at the crossroads to make sure that, that alignment is there. And then you also mentioned about the quality, and Weedy had an amazing presentation from NCQA in our emerging technology series. Rob Tennant, Ed Hafner brought in NCQA leadership to discuss about a lot of initiatives on digital quality measures. So again, for the membership on this call, there's so many other resources here at Weedy that are exploring everything that Fred's talking about. And just to wrap up, I know we've come a long way, right? So what you've described was a lot of difficulty. Then today we've come a long way, but from what you're talking about and the complexity, there's still a long way to go. Just to wrap us up, Fred, and I know you're very equipped to answer this, but I just hope it could be concise, is in the future, do you see anything on the horizon where some of these additional complexities are going to be solved? Providers are going to be a little bit more happy. We know they always say, well, the structure of this program, the structure of this value-based contract doesn't address my patients. My patients are sicker. Is there anything in the future that's going to solve that for us?
Yeah, I think as an industry, we've come a long way on that. And there's work we're doing at Edifecs. I know there's work happening at some of the other companies. Some of the folks are on the call, I believe, working in this area to address those concerns, because we've been hearing it for years. I've been seeing it for, decades, that need. And I think we're finally at the critical mass where we have the tools, we have the information, we have hopefully the interoperability to start supporting that whole end-to-end part of the contracting the contract support, the visibility, the transparency, the payments and all of that, so that the providers can be successful. Because again, at the end of the day, they're the ones providing care. And I just like anything else, I think if you've ever looked at the CFR, the federal regulations for just like the IPPS for DRGs, whatever, it's like 675 pages of regulations. Providers generally aren't dealing with that. I mean, that's the legal staff and quality staff and probably 100 people at a big organization dealing with those. But even if you're talking about simple programs, we have heard that it is difficult for providers to manage multiple payer contracts. Even in a single market, you could have 5, 8, 10 payers doing 5, 8, 10 different things, that these provider organizations are having to send reports and maintain systems just as to know the same measure they're recording for each of these 10 different payers, for the slight variation in contracting for each of these 10 different organizations. So providing a way to simplify, to standardize and consolidate program designs, model designs, terms, conditions, and even the measures, I kind of contradicts a little bit what I'm saying, but if we're specializing, that's fine to address certain care needs and certain financial needs. But overall, we shouldn't have such a wide variety of, if I'm an episode with here, I shouldn't have a completely different set of terms and contracts and quality measures for the episode I'm doing over here. That's the same episode, just to simplify it. So we need to really provide, I think, that level of simplification, standardization, and automation to help our providers be successful in giving us better healthcare.
Well, it sounds like an organization like WEDI and our sister and brother organizations like CAQH, Da Vinci, NCQA are all coming together on this. So thank you for that snapshot of what's coming down the pike. So I'd like to open it up if anybody wants to unmute and ask Fred a question, or Sam, if you see any questions for Fred in the chat, this is your opportunity. Okay. Give it another 3 seconds. Anybody want to ask Fred a tough question? Tougher than I have? Okay. Well, I'm honored to be a colleague of yours, a good friend, Fred. For the folks on the phone, he continuously invites me to stop by his house. I pass it multiple times a year, and he always says, stop in. Someday I'm going to do that, and hopefully you got a nice sweet tea for me. So thank you very much, Fred, and I appreciate you being our first guest speaker, and thank you. All right.
Sure, my pleasure.
All right. So in the chat, all right, thank you. Couldn't be on the presentation. Okay, terrific. So let's move forward, and maybe we can give everybody 5 or 7 minutes back. So this is the part of where we're gonna have an open discussion. So any questions, any comments, any future suggestions to, how we're gonna lay out next meeting. I'm still working on getting another speaker for October. Any suggestions? And please also, if you know somebody within your organization that can come and speak to the membership, that would be amazing. So again, always have an open line to myself and to Sam. We meet the 4th Tuesday of every month. We have some work. Our sleeves will be rolled up over the next 2-3 meetings in order to get our draft ready for submission to WEDI approval. And quite excited about it. So any last comments or? All right. Quiet group, but large group. Thank you so much for joining. I hope you can join again next month on top of hopefully having a guest speaker. We're going to get down to some brass tacks, go looking at, drafting certain these sections, maybe farming out some work multiple times. In the last white paper, we, did that same concept. It worked out well. It gave us a well-rounded contribution and a, overall very acceptable white paper from multiple perspectives, whether it's payer, provider, or supporting organizations. So again, thank you so much for joining us today, and everybody can get 5 minutes. You can get to your next meeting on time. Again, thank you so much.
Thank you.